Good evening. My name is James Boyer in the Colorado School of Public Health, and I'm here to talk to you about the Boston Marathon bombing. Or explosion of two improvised devices at the finish line, immediately resulting in three fatalities that occurred on scene, over 100 patients transported by ambulance, and over 200 total casualties from the disaster itself. These explosions occurred at the finish line about 13 seconds apart and about a block away from each other. The disaster resulted in an almost immediate mass casualty incident response by local responders, and a subsequent law enforcement investigation and finally apprehension of two suspects. And an important focus of the disaster response was the physical recovery at the disaster location, as well as the resiliency of the community, which we'll discuss. Some key players locally here are listed on this slide, most notably the EMS, fire, and law enforcement. And you'll notice in that sub-bullet that there are numerous jurisdictions noted. A unique characteristic about the Boston Marathon is that, unlike many races, which are a circle, which the finish line and starting line are basically at the same location, the Boston Marathon is one continuous course that is straight. So it starts in an outlying suburb of Boston, and it ends in downtown Boston. So all those jurisdictions listed are different towns and cities in which the race goes through. Another notable list here are the private ambulance services located on the right-hand column there. And these are ambulance services that do patient transport, but usually transport in a facility. So they take a patient from one facility to another rather than do an emergency scene response. But these become really important players with the initial response to the disaster. Here we have some state and federal players. Most notably on the state side is the Massachusetts Emergency Management Agency, the Massachusetts National Guard. On the federal side, it's all the players you'd probably expect with an explosion disaster. The FBI, Department of Homeland Security, FEMA, and interestingly enough, the National Weather Service. Finally, we have key players of hospitals, as well as private and nonprofit organizations, such as the Red Cross and Salvation Army. This is going to be important for the post-disaster recovery. We also have listed on the first column the Boston Athletic Association, and they oversee the pre-planning for the event of the race itself. So less to do with the disaster side of things and more to do with the pre-planning for this event. Here's a list of hospitals, all of which receive patients from the disaster or the explosion by ambulance or walk-in. So as we discuss the Boston Marathon bombing, this is a really unique disaster in that it occurred at an event which was already using ICS and pre-planning. It's not like this explosion occurred in the middle of a street on a work day where agencies would then have to respond. Instead, the explosion happened at this large-scale event with thousands of participants and thousands of spectators, to which was pre-planned and had a large number, as you saw, of agencies already present and prepared for a similar event. So it's a really unique in that essentially this was planned for, obviously not predicted, but agencies were ready, and you'll see that the response was efficient and effective. So with that, the Boston Marathon occurs every year in April, and the pre-planning actually starts in January of each year. So there's months of coordination and pre-planning by these agencies, specifically, again, these local public health EMS fire agencies, as well as emergency management, National Guard, and that Boston Athletic Association. They do a number of tabletop scenario exercises, which interestingly, the year prior, one of their larger tabletop scenarios was a collapse of a grandstand that was filled with people, resulting in a number of casualties, requiring ambulance transport to hospitals. So not an instance too unlike what actually happened in 2013. Another important aspect to this pre-planning is the application of lessons learned and best practices from years prior race day events. And in 2012 was one of the hottest race days on record, resulting in environmental exposure and heat-related injuries to not only spectators but the racers themselves. So not only the running of 26 miles, which is wild, but also doing it on a really hot day, resulting in those heat-related illnesses and injuries. So the big lesson learned for the 2013 event was actually this enhancement of medical support systems. And what that looked like in application was a total of 26 medical tents along that race course, 8 of which were enhanced medical tents, meaning they had higher capabilities than you might expect just at a first aid tent at an event. 2 of those 8 enhanced tents were located close to the finish line. They're referred to as the Alpha and Beta. That's just the names of them. And these were both enhanced medical tents prepared for potentially, another heat wave or similar number of patients that they could alleviate. And the idea of this enhanced medical tents is to, in the instance of another high influx of patients, to help alleviate the stress on the hospitals. So rather than having these folks transported as patients in an ambulance to a hospital, if they could just be treated effectively on that scene in the tents, we've avoided the transport and the stress onto the hospitals altogether, which is good for everyone. When we look at a timeline of just the initial disaster, notice that it's just under an hour, which is impressive that everything got done. When we think about the scale of this disaster itself, at 2:49 is when the explosions occurred. Again, there were 2 of them, 13 seconds apart and about a block away from each other on Boylston Street. And keep in mind that the race is still going on. People have finished the race by now, but people are still coming in, crossing the finish line, and there's a large number of spectators at this area. And immediately when these explosions go off, you have responders that are close to this location. So immediately they just walk over or run over probably to help starting the triage and treatment and communications of this disaster. Put yourself in the shoes of these boots on the ground for just a minute and imagine that not 1, but now 2 explosions at a really large, high-profile event have just happened. And scene safety is paramount with all emergency response, especially these large-scale ones. And these responders don't know if there are subsequent explosions that are going to happen. They don't know if people are going to come out shooting. So just keep that in mind as you're thinking about what this incident response would look like. But just minutes later, hospitals are notified of the MCI, so they can prepare their emergency operations protocols. And only 6 minutes after the explosions occur, the Boston EMS mutual aid radio request is calling for additional ambulances. So if we think back to the key players, this is going to be those other ambulance agencies that do a lot of interfacility transports, but also support local jurisdictions and their response needs. And with that request, 10 agencies in total are responding. That includes Boston EMS, which has primary jurisdiction over this location, and a total of 73 ambulances respond, which is impressive. And they respond to not just anywhere, because just imagine 73 vehicles to any given location is going to be chaotic, but they actually have 2 predetermined staging areas, and that was all part of the pre-planning with the ICS over the months prior to the event. By 2:57, most hospitals have now fully activated their emergency operations center and protocols, and the ones that hadn't done it already were few. Many of these hospitals already had the EOCs up and running just with the race day itself, and now other ones had followed suit with the explosion and the disaster that occurred. Not even 10 minutes after the explosion, your first ambulance with a critical patient is leaving the scene en route to a local hospital. Something that's really important with disasters is looking at destinations and where these ambulances transport to. If you have a response of an ambulance just to 1 patient, they most likely will go to the closest hospital, assuming they have the capabilities that patient requires for their acute injury or illness. But when you have a scene with over 100 patients being transported by ambulance, you can't just bombard 1 or 2 hospitals with all of the patients. It's just not going to be feasible for that hospital to manage. So what's done in Boston is the Central Medical Emergency Direction has a large-scale view of all the hospitals what their availability and bed space is based and what their capabilities are, which can then be married up to the patients on scene and their needs based on their injuries. And basically, this system is determining which patient is going to which hospital. That information is relayed to an on-scene officer, and then that officer tells each individual ambulance which destination they're going to go to in order to better disperse all these patients and not bombard one hospital with all of the patients. We look back at the timeline. At 322, the Boston Emergency Operations Center is operational. And this is to care for this disaster, keeping in mind, too, that all of the other quote-unquote run-of-the-mill or ordinary emergencies are still occurring, requiring emergency response by EMS, fire, and police. At 328, the Unified Command Center is established physically inside a Westin hotel, which is proximal to where this explosion has occurred. And then at 337, so again, less than an hour after the explosion, the final critical patient is transported from the scene by ambulance. You'll notice that 73 ambulances responded and transported over 100 patients. So imagine some of these ambulances are leaving a scene with a patient, going to a hospital, and coming right back to get more. And or ambulances are capable of taking more than one patient depending on their severity. So an ambulance might have taken 2 or even 3 patients to any given hospital to account for that mismatch of ambulance to patient transports. This is a great diagram that illustrates what I talked about as far as the EMS transport and dispersal of patients. The first pie there on the left indicates the ambulance service and the amount of patients they transported out of the total. Obviously, Boston EMS transported the vast majority of them, which makes sense. Again, it's their primary jurisdiction, and they would have had higher staffing and ambulances available that day for just the race day itself. And then you do see the numerous other ambulance agencies that provided mutual aid support and transport for patients from the disaster. The next pie on the right side indicates each hospital that received patients from this disaster. And this really shows the effectiveness of that hospital dispersal system, in that not every ambulance just chose willy-nilly of what hospital to go to. Instead, it was a deliberate decision from a systematic approach of what hospitals and what their capabilities are. Obviously, there is some variation between these facilities. However, it's not very big. And you'll note that the BWH, that's Brigham and Women's Hospital, that is a level 1 trauma center, which means it has the highest capabilities for treatment. And it's going to be a larger hospital than those smaller slivers that receive fewer patients. So they're going to have higher capabilities as far as the number of patients they can handle. The post-disaster recovery is really the time after that last critical patient was transported, and looking at the little bit less acute things that need to be addressed and responded to. Most notably, thousands of runners that are still on the race course, again, which is 26 miles long. So there may be runners that were still miles away from their destination, which probably don't have a cell phone with them, and that may or may not be close to a spectator that they know, like a family member or a friend cheering them on. Mental health care for community members, that is responders as well as community members in the area from the explosion itself. Also, hospital reunification of patients and families. You can imagine that the capabilities and timing just isn't going to be there with ambulances picking up critical patients from the explosion scene. It's not going to be feasible for them to call family at that time to let them know which hospital they're going to be transported to and cared for at. Next, a family assistance center was opened, and this was to provide support for victims of the explosion itself, as well as their families. This is going to be logistical support as well as financial. And then finally, reopening of Boylston Street. Again, Boylston Street is where this explosion occurred. And of course, it was a disaster location, but then it was a crime scene that required investigation. But reopening that street was important for the public and for families. And after it was opened and physically improved from the damages, ceremonies were held. One private ceremony for the family of the victims, and then another public ceremony where anybody could come and kind of pay their respects. Keep in mind, we're just looking at the public health aspects of this, but we still have 2 suspects at large for days after this disaster, because this was an improvised explosive device that went off. So law enforcement operations are still happening, which ultimately will lead to the apprehension of suspects, but that's going on along with this disaster recovery. The community resilience piece of the Boston Marathon bombing is impressive. Boston Public Health Commission trains thousands of professionals annually. These are volunteers that reach out to the vulnerable populations, and they have medical credentials. However, Boston Public Health Commission lacked a response plan for mental health disaster, which, at first thought you wouldn't imagine that perhaps an explosion like this would have a mental health impact, but of course it does when you think about the stress and the impact to the responders and families and victims of that event, not to mention the community at large. A term that was coined pretty quickly that even I heard living on the other side of the country, this Boston Strong, and I think it's still present in the community. And it was kind of a way that the community took pride and took ownership of their resiliency, truly, with this disaster. Um, the term terrorism was definitely used in relation to the bombings, and Boston Strong was kind of a way that people seem to be able to take their pride and kind of feel stronger than the terrorists may have wanted them to. Some best practices that were noted looked especially at the pre-established mutual aid agreements and communication notification systems and unified command of local agencies. Again, that month-long of pre-planning just for the race itself lent itself perfectly to apply to an actual disaster that occurred at the event. Even though it maybe didn't match up to an exact tabletop exercise, the use of ICS and its flexibility just worked really well to respond effectively to this event. And instead of one of the tabletop scenarios, it was able to be applied in reality to a disaster, which had hundreds of victims. Another best practice was the EMS transport and that patient distribution that we talked about a little bit extensively, and then also a coordination of public messaging, and that was for the public health aspect and recovery of the system, as well as that law enforcement piece and the community resilience of the Boston Strong message. Some areas of potential improvement include enhanced security for large public events, an earlier activation of the Boston EOC. If you recall, the EOC wasn't open until after the disaster, and it was recommended that it probably should have been open just during the race, just for the possibility of such a disaster. It was recommended also the use of MCI triage tags, and what these are, if you're not familiar, is a physical ribbon or paper tag that is attached to a person, maybe around their neck or pinned to their shirt, that indicates by a color the severity of their injuries, so that you can more easily identify people that have higher acuity or worse injuries than others, and which need to be transported more rapidly or earlier. On a similar note, tracking of patients that were transported by EMS, we talked about this dispersal of patients to different hospitals. However, actually tracking those people would have alleviated some of the matchup for families to know where their loved ones were transported to. When you think about HIPAA and privacy laws that hospitals have to abide by, it made that process a little bit tedious and challenging. Also, a wider availability of tourniquets was recommended, and this was for that immediate treatment of life-threatening arterial bleeds in people's limbs. And if more tourniquets on scene were available, there may have been a more effective use of them and application to victims that sustained serious injuries from the explosions. Finally, a recommendation for improvement would be a development of a mental health plan by the Boston Public Health Commission. Some effective changes that seem to come out of this disaster response were a nationwide and more so even around the country, or I'm sorry, around the world, of wider acceptance and training and use of tourniquets by first responders and as well as lay people. The American College of Surgeons put out a Stop the Bleed campaign a number of years ago to advocate for the use for tourniquets and showing their efficacy as well as their safety for even lay people to use effectively. Additionally, any one of you that might have gone to a large public event over the past few years has probably experienced enhanced security. So limiting backpacks, which was the way that these improvised explosive devices were snuck into the setting, as well as video monitoring, metal detectors. Finally, improving that tracking of patients transported by EMS is something that a lot of EMS agencies across the country have experienced. Thank you for your attention, and that's all I have for you today. Thank you.